video conferencing and technology is a wonderful thing. So even though I'm not with you in person, I can be with you in spirit. And I've been asked very kindly by Veronica to give you a bit of an update on syphilis. As you all know, syphilis is my favourite infection. It's pretty awesome because it's been around with us for so long and it just keeps popping back up no matter what we do. It's kind of always there. So I have a very strange respect for it, even though one of my main jobs in life is to control it. So today we will be talking about a couple of clinical vignettes. So these have been de-identified and they are not real people, but they do illustrate many of the points that we're trying to get across with the effective control of syphilis. We'll also be talking about raising the conversation about sex and STIs with your patient. What are the tests that we do for syphilis? How it presents clinically, the clinical management of syphilis, the public health management of syphilis, and then at the end be thinking about, well, what are your take-home messages from this and how will you do things the same that you've been doing really well, and what might you do differently in the future? So we're going to start off with a quiz because I love quizzes and they always get people thinking and talking. So here's our first quiz. So we've got a previously well 25-year-old female who comes to us with persistent headaches and fever, no other symptoms. The doctor or nurse or Aboriginal health practitioner who sees her happens to do a syphilis serology, and that shows RPR of 32 and a positive TPPA. So if these symptoms are due to neurosyphilis, is it true that she must have tertiary syphilis? And the answer there is false. So what we've been seeing now is that syphilis we've always known that syphilis can present as neurosyphilis at any stage of syphilis. And we used to not see that, but now we actually are seeing it. People, including young people, presenting with neurosyphilis in a very early stage of their infection. So we'll move to the clinical vignette now. So this is a woman in her 20s. She's having her first baby. She had all the appropriate antenatal care, including a full suite of standard investigations at the first antenatal visit, the booking visit, and her syphilis serology at the booking visit was negative. She presents in her third trimester with pelvic pain and multiple painful genital lesions, which are thought to be herpes. So no investigations were done. They were clinically diagnosed as being consistent with herpes, and she was treated with antiviral medication. 3 weeks later, though, the lesions still were not resolved. So luckily she was seen again and she was swabbed with a PCR, which showed that it was syphilis. And then her baby was born with congenital syphilis, required a prolonged admission in neonatal ICU, and unfortunately is likely to have long-term disabilities because at the time of birth it's got the bony problems with syphilis and also had a big liver due to syphilis. So we found that syphilis has been flying under the radar because not everyone is aware of just how common it has become. These atypical presentations are increasingly common. So, we all think of syphilis lesions on the genitals as being a single lesion and it's painless. And that's what I learned at medical school. But, I've seen people in the M clinic where I work clinically, they come with this lesion. You think, oh my God, that looks so much like herpes. You take a swab of it and it's painful. It comes back positive for syphilis. So we just need to be really aware that it might present in its typical way, but it also might present in a very atypical way. So it's important that if we see, any lesions that could be syphilis on the skin of the genitals or on the mouth or anywhere really, that we swab them. And that pregnant women, they need to be tested for syphilis, not just at the booking visit now, but also at 28 and 36 weeks, regardless of which part of WA they live in, regardless of whether they're Aboriginal or cold or non-Aboriginal. And that pregnant women in the Goldfields, the Kimberley and the Pilbara also need to be tested for syphilis at the time of delivery and at 6 weeks postpartum, in addition to the testing at the first visit, 28 weeks and 36 weeks. And congenital syphilis is costly, not just in terms of the dollars, but in terms of human suffering. So it's really important that we prevent that. And in the 21st century, when we have an infection that it's easily tested for, it can be easily treated for, there is no antimicrobial resistance, it really begs the question, you know, why are we seeing increasing numbers of congenital syphilis in our community? It really is it's a great worry to me that we see this. And it's a huge indictment on our health system, you know, like, why does this happen? So we'll move on now to, you know, how and when would you start a conversation about STI testing? So we would recommend that, you know, you bring the subject up opportunistically whenever you can. Now, that doesn't mean that if someone's coming to you in emergency department with chest pain and an MI, we start talking about STIs right then. You know, you're all experienced clinicians, so you know when to do it, when not to do it. But, you know, say if we have someone who doesn't come to the clinic very often and they've come, say, for repeat prescription for something, or, you know, with a, you know, they've sprained their ankle, deal with that, but then also use it as an opportunity to say, well, what about STIs? You know, are you sexually active? If someone's already coming, say, for something that is related to sex, say, a repeat prescription for the pill, or, you know, Implanon, or they might be coming to ask you proactively, what can I do to maximize my health before I get pregnant? Then that's a really good opportunity to start talking about sexual health and STIs. And we also have people who will just proactively walk in and ask for a checkup, and that's to be commended at all times. So it's important that we normalize talking about sex, and just say to people, look, I will be asking you some personal questions, and that's so that I know what sort of tests to take, what sort of swabs to take, and where I should take them from. And that I ask everyone these questions, because, you know, if I don't, I wouldn't know how to do my job properly. And a lot of people don't know that STIs are common and that they can be asymptomatic. So, you know, the reason why we do the testing, even though people don't necessarily have symptoms, is that they might have the infection. It could be making them sick inside. They don't know it. They could be passing on to other people not knowing it. So it's always good to have a checkup. And it's important that we don't make any assumptions. So we are careful with the language we use. You know, we don't use pronouns that would make the patient assume that they only have partners of a specific gender. We don't assume that if we know someone is married or has a regular partner, that they don't have other partners in addition. So we can start off by asking, you know, firstly, are you sexually active? And then, you know, who are you having sex with? You're having sex with men, women, both. What kind of sex do you have? You know, is it vaginal, anal, oral, all of those? And then when did you have sex? And when did you most recently have sex? When did you have sex with, you know, each of the partners that you've been telling me about? You know, have you had recent partner change? And to always be reassuring people that the reason why we're asking these questions is so that we know what tests to do, where to take our swabs from. It's not just because we're, you know, being sticky beaks. And to keep reminding people that this is a confidential conversation. And everyone has a different definition of sex. So it's important we don't make assumptions and that we ask in, quite clear, objective language. Well, tell me what do you do for sex? And if people are using words that we don't understand, like I remember when I was first told about felching, I said, oh, I've not heard of that before. Can you please just tell me what that involves? And then the patient can tell you in their own words what that involves. Then I would think, okay, well, given what you've just told me, I can see that that could be putting you at risk of hepatitis A. So I would need to be ordering a hepatitis A serology in you, as well as the other blood tests that I would normally, be ordering. And people are really, I find people are quite comfortable with telling you what that sexual practice is if it's something that you don't know, as long as you approach it with with an attitude of genuine sincerity and genuinely curious about, well, what is it and how do I translate that into medical risk and the tests that we need to do.
So, Donna, can I ask what is felching?
Oh, what is felching? Yes. So felching is something that gay guys tend to do, but I don't think, I mean, it probably may not be exclusive to gay people, but that's where I heard it from. So it's when you ejaculate into someone's bottom, then you put a straw in it and you suck it up afterwards. So clearly it is a risk for hepatitis A transmission.
Okay.
And I suppose, I mean, could a woman do it? I guess a woman could do it. She'd have to have a very long straw, or perhaps if they were having a threesome, she could do it anyway. I haven't heard of a woman doing it, but yeah, there you go.
Well, thank you. I
Yeah.
just, thanks.
Yeah, so screening and testing for syphilis. We'll move on to that now, and we've got our next quiz. Hopefully you should all be able to answer this because it was in a previous slide. Okay, so that's correct. The syphilis testing that should be routinely offered to all pregnant women in WA is we test at the booking, the first visit, 28 weeks, 36 weeks at time of delivery. And then if they're from the Pilbara, the Goldfields or the Kimberley, they also need it at the time of delivery and 6 weeks postpartum. And this just gives you an idea of how well we are doing in terms of meeting those testing guidelines. Now, unfortunately, we only have the data for the Goldfields, the Kimberley and the Pilbara. We are working on getting this data routinely reported across the whole of WA. We're not quite there yet. And so you can see from this graph that the Kimberley is doing probably overall better than everyone else. The Goldfields is doing better in terms of testing people at the time of birth. And everyone needs to do far better in terms of testing people at the time of birth and at 6 weeks postpartum. But that's kind of like a mop-up. Because if you're not testing someone until the baby's born or 6 weeks postpartum, if the baby's got congenital syphilis, you have no chance to intervene. The opportunities where everyone needs to do better across the board is testing at 28 weeks and 36 weeks, because, those bars should be the same as what it is for the first visit, which is around about 90, 100%. That's the testing that gives you the best opportunity to pick up syphilis in a pregnant woman and treat her in time to protect the baby from getting congenital infection, which spreads through the blood into the placenta and into the baby. So just taking a step back now, like who should we be testing for syphilis? So if we've seen someone who's asking for STI check, or they've come in and we've opportunistically had a conversation with them so that they're happy to have an STI check, well, then we should always be offering a syphilis test as part of that. So women who are pregnant or they are thinking of becoming pregnant, we should be offering them a syphilis test. Men who have sex with men, they're a high-risk group. Aboriginal and Torres Strait Islander people, high-risk group. And then we've got these other high-risk groups, people who are homeless or couch surfing. That's a recent addition to our high-risk groups. Sex workers, and especially people who are what we would call informal sex workers. So they're exchanging sex for drugs or for alcohol or for a safe place to sleep or food, because they don't have the same access to resources that people who are, I guess, working in a brothel, and, it's much more part of their job. They've got a lot more access to resources and knowledge. Anyone with a rash that you can't explain immediately, we should probably be thinking about syphilis. Anyone with any kind of a genital or an oral skin lesion, we've sent the syphilis alert out to dentists, and there have been people who've presented with, a strange ulcer or a lump on their tongue. It's found to be syphilis. Any sexually active person who has a strange rash on their skin, it may well be syphilis. And, I remember very vividly the case of secondary syphilis that I missed when I was a very young doctor, some, 30 years ago, when I was working in the Kimberley, and a young woman had come in. She was traveling from Central Australia into the Kimberley, and she had this rash kind of just around her ear, and it looked like ringworm. That looks like ringworm. Anyway, it wasn't ringworm. I did take a test of it. By the time I figured out what it was, because the test took some weeks to come back, there was a string of young men who were coming in to see me from that same community who had figured out that they had got syphilis from her. They'd all told each other, and yes, and then by then she had gone back to the Northern Territory, so we had to, do a referral, cross-jurisdictional referral. I don't know if she ever got treated, but whenever I see anything that looks like that, I'm always very wary of it now. And then the other thing that people are presenting with, which is really unusual, but, another manifestation of neurosyphilis in the early stages of primary or secondary syphilis, is neurological presentations with like cranial nerve palsies. So it could be that, one of the eyes isn't moving with the other. A recent patient in the Goldfields presented to an ophthalmologist with just gradual loss of vision. And it took some months to see a public ophthalmology clinic was found to have retinitis due to syphilis. So, all these weird and wonderful things, think about syphilis, and especially, I'm talking to a bunch of people who work in primary care. I'm not saying don't refer them to an ophthalmologist or to a neurologist or whatever, but perhaps you do the syphilis test before you refer them, because if you find out it's syphilis, then you can treat them straight away. And if they get better, if it's neurosyphilis, you actually need to refer them to a sexual health physician, because they will need to have 14 days of IV penicillin. But that will mean that they get treated earlier than if you don't do the syphilis test and they're waiting for months to see the specialist. And if it's a strange manifestation like a skin lesion or, an ulcer on the tongue or something, you just treat them the way you would normally treat them, and their syphilis will be cured. So you don't have to remember all those priority populations. They're in the Silver Book. And in the Silver Book, on the landing page, we've also put a big blue icon there about syphilis and pregnancy. So that's just to constantly remind people, when to test pregnant women for syphilis. Okay, so how do we test for syphilis? So there are 3 tests that we do for syphilis. 2 of them are blood tests, and 1 of them is a swab test. So the blood test is the most common one. We would always do that. And when we take the blood, you just ask for syphilis serology. That's all you need to do. The lab will work out the rest. The first test they will do is the enzyme immunoassay or an antibody test. And some of you may also know this test as the TPPA or the TPHA. It tests for the body's, our body's response to syphilis, which is to make antibodies towards that particular germ. Unfortunately, these antibodies don't do a great deal in terms of protecting us, and it will tell you whether someone has ever had syphilis in their life. So once they've ever had syphilis, that test will stay positive for the rest of their life. So you might think, well, that's not much use, is it? Because if I know someone's had syphilis before, or if I've treated them for syphilis before, then that one's always going to be positive. So the other part of the blood test is called the RPR, or the rapid plasma reagent. If the EIA is positive, the lab will automatically do an RPR for you. You don't have to ask for it. It's reported as a dilution or a titer, and if it's a big number, that is telling us that the syphilis is very active in that person's body. And if it goes from a big number to a smaller number after we've treated that person, it's telling us that the treatment has been successful in curing the person of syphilis. So it's a really, really useful test. The way that it's done in the lab, it's quite subjective. So if you are following someone up with syphilis after they've been treated, it's really important that the blood test keeps going to the same lab, so that we get a consistent reporting of the RPR. The other test that we can do is a swab. So it's a PCR swab looking for the DNA of syphilis. And we can do that if someone has a skin lesion or a genital lesion of any sort. Just take a dry swab of it and ask for a PCR test for syphilis and herpes. Those are the 2 sort of STIs that people generally tend to have. Sometimes they have both. And that will help us to work out what stage of syphilis they have. And we'll be talking about syphilis staging very soon. Okay, so this is what the syphilis serology could look like on the pathology report. And so you can see here that the TPPA, or the antibody test, is reactive. And because it's reactive, the lab has automatically done an RPR, which is 256. So that means that they're still able to detect this RPR at 256 dilutions. So there's a lot of it around. So this is telling us that the person has got active syphilis. And if the RPR is high and it's rising, it means that the person's syphilis has not been treated. If it's falling after treatment, that's an indication that the treatment has been successful. Many people will continue to have a low reactive RPR even after successful treatment. So this person, say their peak RPR was 256. Say if 3 or 6 months later, it had dropped 4-fold, which is to 64, then that is a successful treatment. And it may over time drop down to, say, I don't know, 16 or 8, and they might just stay like that forever. No, that's okay. If we test them again and say it's gone up again, that probably means that they've caught syphilis again. Now, sometimes the RPR is so high that it's kind of off the scale and it comes back as a false negative. And that can happen in the, if someone has got primary or secondary syphilis. And the way to deal with that is to repeat the RPR, because then it might come down, say, to 1 in 1,024, and you think, oh, that's really high, but that it was actually higher before. It was just immeasurably high. And if you do have someone who's got clinical signs of syphilis, and the RPR comes back negative, and you think, that just doesn't seem right, you need to treat them. Don't send them off. Oh, we'll see whether your RPR comes down before you treat them. No, just treat them, but keep measuring the RPR. And then the PCR test. So that's useful if they have skin lesions, and it does help to distinguish syphilis from herpes and from other conditions that are non-infectious. And if they've got a positive swab result for syphilis on a skin lesion, depending on what the skin lesion looks like, it means that that person has got primary or secondary syphilis. That's really useful, because if you have someone who has never had a syphilis test before, and you know that they've got primary or secondary syphilis, then that means that they can be treated with one dose of LA Bicillin once, as opposed to, if you didn't know, you would actually have to give them that treatment every week for 3 weeks. What happens with the RPR over time? It will gradually reduce after treatment, and even if you don't treat the person, it will, over time, it will gradually reduce, but that's not really a good thing to do, because they stay infectious for a long time. And even if all their symptoms go away, they could end up getting tertiary syphilis, so 10 or 20 years later. We don't want people having to go through that. And the antibody test, that stays positive for life. So for those of you who are working in services where you've got the rapid test or the point of care testing, that point of care test actually tests for the antibody. So there is no point in doing a point of care syphilis test in someone who has already been treated for syphilis, or who tells you, I've had syphilis before, because it's just going to be positive. It won't tell you whether they have been reinfected with syphilis and they need to be treated again now. Okay, so I've got another quiz question. So which of these tests stays positive for life even after successful syphilis treatment? And the answer to that is the EIA, the antibody test. Okay, so now we'll go to the clinical presentation of syphilis. So the chancre of primary syphilis, does it always resolve spontaneously without scarring? What do you think? Now, if you said true, that's what I used to think as well, until I saw this article. This is a recent publication, and this is quite horrific. So this is a patient with syphilis and HIV. That large lesion that you see on her, lips and nose is the chancre of syphilis, and even after she's been treated, she's left with lifelong scarring. Now, that's not what we usually see, but it is possible. So how does syphilis present? So we have these classical 3 stages of syphilis: the primary stage, the secondary stage, and the latent stage. And then, if they don't get treated after that, then the tertiary stage. Now, remember what I said before about syphilis often presenting in strange ways now. So although we've got these distinct stages, sometimes they overlap. So the primary stage, which generally happens 10 to 90 days after the exposure to syphilis, it happens at the site of exposure to syphilis. So that could be in the mouth, the genitals, the anus, anywhere. People can even get it on their finger. Is an ulcer which is typically a single ulcer and painless, but it can also be multiple ulcers. They can be painful. And so they might be misdiagnosed as herpes, trauma, and anal fissure. If you do nothing, don't give any treatment, it will go away eventually. That doesn't mean that the disease is gone, though. It just goes inside their body, comes out again later. And then the secondary stage is where the syphilis is spreading all around the body. It can happen from 2 to 24 weeks after the exposure. People can get systemically very sick, so they can feel like they've got a really bad flu, they're feverish, they've got aches and pains all over, big lymph nodes. They can have the rash, and the rash can look very different on different people. So that's one example of the rash, but it can look so different depending on who it's in. And then they can also get this, neurosyphilis as well. And if you do nothing about that, after a while, all those symptoms will go away and the person will have no symptoms. But for the first 2 years, they potentially are still infectious. So here's some pictures just to show you how variable this chancre of primary syphilis can look. No, secondary syphilis, the rash it's diabolical. It can just look so different depending on who it's happening in. And that classic rash that we've all learnt about, when we were at medical or nursing school or whatever, on the palms of the hands and the soles of the feet. Yes, it may be there, and there are very few rashes that occur on the palms of the hands and the soles of the feet, but the rash of secondary syphilis is just as likely to be in any other part of the body as well. And these things here, they're condyloma talata. You might think that they're warts, but they're not. They're actually lesions of secondary syphilis. You might look at that and think, oh, it looks a bit like thrush. It's kind of pink and moist, but no. That's also condyloma talata. That could easily be mistaken for ringworm. That you might think, oh, I don't know what that is. I'll send that person to the dentist. And, if the dentist isn't clued up about syphilis, they could be thinking that's cancer. So, you just got to be really careful. These things can look quite strange. Then we move to congenital syphilis. So for me, this is really the pointy end of syphilis because, the baby has absolutely no choice about its sexual practices and like it's just been in mum's tummy and doing nothing risky at all, and it gets this. So, it's entirely preventable. And if we can, as a healthcare system, make sure that pregnant women feel safe to come for antenatal care, and we test them at booking at 28 and 36 weeks, then we can prevent this altogether. And the important thing, I think, is that they feel safe to come to us. We've had cases of babies born with congenital syphilis and even stillbirths where the mother hasn't felt safe to come to antenatal clinic, either because there is no clinic in that remote location, or perhaps the clinic is staffed only by a male, or she's had children taken away from her by DCP in the past, and so she's trying really hard to hang on to this child and thinking that hiding her pregnancy is the best way to do that. Of course it's not, because then once she has a baby with congenital syphilis and DCP sees that she hasn't been going to antenatal clinic and hasn't been engaging in care, and it's more likely that she gets that baby taken away from her, or she loses it because it's a stillbirth. That's even more tragic. So the other part of preventing congenital syphilis is that it would be ideal if women come to antenatal clinic with their partners, and so the woman and her partner are aware of how important it is for this testing to happen and how important it is for the woman to stay safe in terms of STI risk while she's pregnant. And we also mustn't assume that women don't change partners while they're pregnant, or that they don't have more than one partner while they're pregnant. So, these conversations I think are really important to have. They don't tend to be the type of conversation that we're taught how to do when we do a diploma of obstetrics, or perhaps when we're doing a degree in midwifery, but these conversations are really important. And Health Department has recently, in partnership with ASHM, released a module on STI and syphilis testing and treatment, especially for midwives, so that we can make sure everyone working in antenatal care has that same degree of comfort and knowledge about talking about STIs and syphilis. And the complications of congenital syphilis, they're horrific. So, we've got stillbirth, preterm birth, death soon after birth, low birth weight, and just permanent neurological conditions like deafness, blindness, syphilis in the liver, syphilis in your bones. Yeah. Okay, so we'll move now to the clinical management of syphilis, and we'll start off with a quiz. So patient has got no symptoms of syphilis, but has got an RPR of 64 and a positive TPPA that's detected on opportunistic testing. So you bring them to the clinic 2 days later for treatment. That's, pretty good, 2 days later. And on the day that you're going to treat them, do you have to collect another blood test before you jab them with penicillin? You already know the person's got syphilis. And so the answer is, that's the wrong answer. That's terrible.
Yeah.
Can we stop that, or shall we just use it as a talking point? I don't know how that happened.
We can use that as a talking point.
We'll just have a talk about it, yes. So
Yes.
some people might think, oh, you already know the person's got syphilis, RPR 64, positive TPPA. Why are you taking another blood test, They haven't miraculously lost their syphilis in the last 2 days. That's true. But it's really important that we take another blood test, because their RPR could have, in the last 2 days, gone up to 128 or 256 or, whatever, even higher. And if we don't take the blood test now, on the day of treatment, then we might test them again for the follow-up in 3 months' time, and the RPR 64, and we think, what's happened? Have they been infected with syphilis again? My treatment hasn't worked. What's gone on? Actually, what went on was that on the day of treatment, their RPR was, say, 512, but because we didn't test it on the day of treatment, then we don't realize that the follow-up results 3 months later, which is 64, is actually really good. She shows that they've been cured. So we must always take another syphilis blood test on the day of the treatment. And we'll fix that slide up for later.
Right. We'll talk about that.
And syphilis clinical treatment, it's so easy. Syphilis is incredibly primitive. It hasn't worked out how to develop antimicrobial resistance. So it's inevitably sensitive to penicillin. And we have this wonderful preparation of Benzene penicillin that lasts in the body for a week. So for syphilis that is of less than 2 years duration, and you would know that because they've had a negative test within the last 2 years, or because you see that they have clinical signs of primary or secondary syphilis. You give them 2.4 million units of Benzene penicillin, and that's it. The treatment is done. If you're not sure how long they've had syphilis for, or if you know that they've had it for more than 2 years, then they need to have that same treatment repeated once a week for 3 weeks in a row. And if they are late in coming, then we have got up to 3 days after that weekly dose is due to give them the second dose or the third dose. But if they go for more than 10 days between, say, the first and the second dose, or the second and the third dose, then it's got to start all over again. this penicillin is the only treatment that will get across the blood-brain barrier. So it is the gold standard treatment. And if someone is truly allergic to penicillin, then they probably should be sent to the immunology clinic and desensitized so that they can have the best treatment that's available. In the meantime, if they're not pregnant, you can treat them with doxycycline, because that, you do actually want to treat them early. You don't want them with syphilis spreading it everywhere. But, if they're, say, a woman of childbearing age, and, well, you shouldn't be, so if they're a woman of childbearing age and they're not pregnant and you've treated them with doxycycline, I would still say send them to an immunology clinic so they can be properly treated with penicillin. Because if they were to get pregnant, it's just not good. And you can't use doxycycline in pregnancy anyway. So if you're not sure whether someone is truly allergic to penicillin, I think, this is where you need to seek specialist advice. And the other thing about treating syphilis is that the treatment is so effective that, all those syphilis germs die. It's like a big die out. And when they die, they're, those dead bacteria can often make the person feel quite sick. So they'll get a high fever. They can be aching all over, just like a really bad flu. That's called the Jarek-Herxheimer reaction. It's not dangerous. It's never life-threatening. It's just intensely uncomfortable, and it can be treated, just with simple analgesia like, paracetamol. And it's a good idea to warn the patient beforehand so that they don't think that your treatment is killing them or making them sicker than what they were to start off with. Given that many of our patients with syphilis don't have any symptoms, we don't want them to be thinking that we're deliberately making them sick. So the treatment comes in these pre-filled syringes. We need 2, 1 in each buttock for the 2.4 million units. And some of you might be asking, well, where do we get this? So, if you're working in an AMS, I think they've, got stashes of it everywhere. But people who are working in private practice, they can get it for free through the PBS doctor's bag. And so we're giving that advice that every, clinic should have this because it's free. It's not that easy to get from a retail pharmacy because it's not, you can imagine it's not an item that walks off the shelf very common, so they don't really have it in stock a lot of the time. So it's important that every clinic has this available to give to people, because we can't be telling people to, oh, here's your script for benzathine penicillin, go and buy it and then come back to the clinic. Like, we'll just lose our patients and they won't get treated. And if you're ever in the situation where you're stuck and you just can't get it, contact MCDC if you're in Perth, or your local or your regional public health unit if you're in the country, and they will give it to you. They have a stash exactly for this purpose. Now, the injection, is it painful? Well, yes, it probably is painful. How painful it is will depend on your injection technique and also on the patient. So there are ways to make the injection less painful. And if someone needs the injection 3 weeks in a row, there's a really good reason to make it less painful so that the pain isn't a deterrent for them coming back for their second and third doses. So PCH has put together a really useful document here about injecting benzathine penicillin. And what I tend to do with my patients in the M clinic is, get it out of the fridge, and while I'm talking with the patient, I tell them, now hold this in your hands like this and warm it up, because that will really help. That, firstly, it gives them something to do, and it is a lot easier to give because it's very thick. So if it's warm, it's a lot easier to inject because it becomes less viscous. And as that injection is going in, if it's at the same temperature as their body, it is also a lot less painful. if you have a very small person or a child, or if there's someone who's like, really petrified, you could try using this technique of drawing up the benzene penicillin in a separate syringe and then drawing up some lignocaine or lidocaine, which is a local anesthetic, in the tip of the syringe so that they have some local anesthetic there. Now, I've not tried this technique. I've not had to use it in the M clinic, but I know that many of you would use this for young children with rheumatic heart disease. And in terms of how to give the injection, we've also got a really useful video that you can go have a look at about, where to give it and how to give that if you haven't done one of these before. So follow-up. The treatment is very effective, but it's not going to work straight away. So people need to be told no sex for 7 days, and their partners need to be notified. The RPR takes time to go down. So usually we say wait 3 months. Now, if you want to do it more often, you can. It's just that if it hasn't come down fourfold, say 1 month or 2 months afterwards, that doesn't mean that the treatment hasn't worked. It just means that perhaps you haven't waited long enough. Now, if you've got someone that you're really worried about because you think that they've had unsafe sex in between you giving them the injection and 1 month later, then by all means do it, because if their RPR is higher than on the day that you gave them the treatment, then yes, that probably means they have been reinfected and you need to treat them again. If it's someone who you think, oh God, I never know when they're going to come back, you happen to nab them, yes, repeat it, because it's better to do it 1 month afterwards than never at all. When you do the follow-up, it's also a good opportunity to do a full STI checkup as well, checking for gonorrhea and chlamydia and repeating the HIV serology, and also to be doing the notification. So we'll talk a bit about that later, about enhanced notification for syphilis, but that requires a bit more information than just the usual notification. So having the patient there and being able to ask them questions is useful for when you're filling out the enhanced syphilis notification form. And at that time of follow-up, it's also a good time to make sure that they have that they're using prevention, protection for STIs, and to confirm that the contact tracing has been done, and if it hasn't been done, to actually do it. And if the person wasn't tested for HIV and other STIs at the time that their positive syphilis test was done, this is also a good time to do that. So now we move to public health management. So firstly, notification. So the enhanced syphilis notification form is really important, and we've recently added some fields to it to help us further characterize the people who are more at risk of getting syphilis. So, in terms of, say, homelessness, drug use. And we had a very bad year in 2019, 2020, where very few of the enhanced syphilis notification forms were being filled in for Aboriginal and non-Aboriginal patients. Now you can see that it has improved, but it's not back to the high level where it was in the previous 5 years. So we really need everyone to get on board and help us to fill in those enhanced syphilis notification forms, because without that information, we don't know who the high risk groups are. We can't target our interventions and our funding to help those groups. So the other really important part of public health follow-up is contact tracing. So if someone has syphilis, but we don't find out who their sexual contacts are, well then, what's the point of treating them, because they're likely to have sex with that person again and just catch syphilis again. That person will go on and give syphilis to other people. So we're not controlling the spread of this dangerous infection within our community. So how far back to contact trace? So if you know they've got primary syphilis, either because of a recent blood test or because of their symptoms, then you go back 3 months plus the duration of their symptoms. If it's secondary syphilis, we go back 6 months plus the duration of their symptoms. And if it's early latent syphilis, then 12 months. And, you know, it's a long time. So we need to give people time to think about it, and we need to be very encouraging, and we need to say that the people who they name, we never tell them who named them. So how do we do the contact tracing? Now, some patients are comfortable enough to tell their partner, I've had syphilis, you need to go and see a doctor, get a checkup and get treated. The typical patient I see at the M clinic, they're all very comfortable with that because within the gay community, it's just part of a normal conversation. Outside of that community, people's level of comfort, I think, is highly variable and tends to be probably less comfortable with it. And, you know, even the gay guys who have sex with women, because some of them have sex with men and women, they're quite happy to have these conversations with their male partners. But when you ask them to have the conversation with their female partner, it's like, no, don't really know how to do that. Don't feel comfortable to do that. So it may well be that they need you to do that, and whether that is you personally to get the name and find the contact, or you getting the name off them and then passing it to the public health unit to find that person. Anyway, either way, it needs to be done. And although it may be very obvious to us why contact tracing is important, we need to explain that to our patients, because they may not be thinking, oh, if the contact doesn't get treated, they could infect me again. They might say, oh, well, I'm never going to see that person again after they gave this to me, so I don't care. And I was like, well, yeah, perhaps you won't see them again, but they could be giving it to other people. You know, they could be making other people sick, and you wouldn't ever want them to cause a woman to, you know, to lose her baby. So, you know, I talk about all those things so that they can understand how important it is for contact tracing to happen. And sometimes we find that, you know, we've gone through all the contacts, we've tested them, we've treated them all, and none of them have syphilis. And when that happens, it's actually really important to re-interview the person and to say, well, yeah, you gave us these names, but actually none of them have got syphilis. So perhaps have another think. You know, what do you think? You know, perhaps someone else who you can remember, because if we don't find that person, they're still out there spreading the disease, and they might at some stage give it to you. So if the patient does want to notify their own partners, but doesn't actually want to like ring them up, then there are some websites that they can, or apps that they can go to, and that if they use these services, they can choose to notify the person anonymously, or they can actually put their telephone number and their name and their email address in that notification. It's up to them what they do. I guess they do run the risk that if the person doesn't know that who's notifying them, then they might think it's a scam and not take any notice. So these are some examples of SMS notifications that people will receive if they use those websites that were in the previous slide. So if you need support for contact tracing, then you can always ring MCDC if you're in Perth, or if you're in the country, your regional PHU. And if the patient wants to have a talk to someone in addition to you about the process of partner notification, they can ring the Sexual Health Helpline, and that's a telephone service that's funded by CDCD. So I've got some key messages here, that syphilis is notifiable, that contact tracing is really important for clinical and public health management. You're all primary healthcare practitioners, and people have chosen to see you, so you're in a really privileged space in terms of doing contact tracing, because people automatically, that you already know they trust you. That's why they've chosen to come and see you. So if you talk to them about contact tracing, it's likely that you will be able to get the names. And contact tracing, it's one of those things that whether it's legally binding or mandatory or whatever, I think it makes no difference, because contact tracing only works if the patient's cooperative and willing to tell you the names. And so that requires trust and having a really good relationship with the patient so that they're cooperative. So we've got our final clinical vignette now. So this is a female from the Goldfields, Aboriginal lady in her 20s. She had opportunistic STI testing when she was visiting Perth, and at that stage, her pregnancy status was not known to the health service. She didn't say she was pregnant. She didn't look pregnant. Her RPR was 32 and she had a positive TPPA. By the time that result was through, she had already gone back to the Goldfields. And it took a long time to notify her, so 6 weeks. When that happened, the clinic in the Goldfields, where she happened to be, did not have any Benzene penicillin on site. They also didn't check whether she was pregnant or not. A week later, she's visiting Perth again, and she goes to ED and delivers a macerated stillbirth, which is approximately 25 weeks gestation, 500 grams. And while she's in hospital in ED, she receives syphilis treatment. She did name some contacts, but none of them had syphilis. So clearly she didn't name all the contacts. And then at 6 weeks postpartum, she's found to have a chancre on her lip. So, highly likely that whoever gave her the syphilis in the first place, because we didn't find them through contact tracing, has given it to her again, and perhaps to countless other people as well. So syphilis in a woman who's known to be pregnant is actually it's a urgent clinical condition. I would even say it's an emergency. As we're seeing more and more syphilis, in women of childbearing age, Aboriginal and non-Aboriginal, across the whole of WA, I think it's really important for all of us to be thinking about offering a pregnancy test or asking about pregnancy test at the time of the opportunistic STI testing. Otherwise you're going to miss it. If you think someone could be pregnant, you think, well, they may or may not come back, they've got no past history of syphilis, consider doing a point of care syphilis test, because if you find out there and then, you can actually start that whole treatment and antenatal care process without waiting. This story underscores how important it is for every clinic to have Benzene penicillin in stock. And also how important contact tracing is, that yes, it can be very difficult, but it's really, really important. So last quiz. So we've got a 36-year-old, no symptoms, RPR 64, positive TPPA, detected on opportunistic syphilis testing. She tells you there's no way I could be pregnant because, I got Implanon. That was put in 4 months ago. So should you still do a pregnancy test? The answer is yes, you should. Not because you don't believe that she's got an Implanon, because you could actually figure it out for yourself. You just need to feel her arm. But it's very possible that she was pregnant before the Implanon was put in. And you might say, well, that would never happen, because before someone gets an Implanon, they always get given a pregnancy test. And yes, that is what should happen. But this actually is a real case where we had a woman with syphilis, and for some reason, I don't know why, when they put the Implanon in, she didn't have a pregnancy test done. So yeah, she was pregnant with an Implanon. So that's all from me. Thanks very much for your time and for your attention. And I'm going to hand over to Veronica now to have a chat to you about what are your take-home messages from this talk, and, you know, in particular, what are you already doing well in your clinic and your practice that you're going to keep doing well, and what do you think you need to do a bit differently? See you.